So I'm now going to introduce the last speaker of today's session, Dr. Jessica Dunne. Dr. Dunne is currently the Director of Screening Initiatives at the Janssen Research and Development's World Without Disease Accelerator. In her role within the Type 1 Diabetes Venture, she's focused on catalyzing and accelerating the global adoption of Type 1 diabetes screening. Dr. Dunne holds a bachelor's degree from Johns Hopkins University with a doctorate from the University of Virginia, and both are in the field of biomedical engineering. Her talk today is titled Precision Prevention of Type 1 Diabetes. We're happy to have you here.
So first of all, I just want to thank the organizers for inviting me here to speak today. I was given a somewhat nebulous title, which is Precision Prevention of Type 1 Diabetes. So not knowing where to start, I actually started with the first consensus report and actually looked to see what the first consensus report defined as precision prevention of T1D. And I created a word cloud. And as you can see, the sort of the two words that pop out here, besides precision prevention and T1D, are really risk and interventions. And so when I think about precision prevention, it's really about defining the risk and then understanding in those that are at risk, how and when to intervene. So for those of you that were on this morning's workshop, you heard a couple of wonderful talks about diagnostics and interventions in this space. And I'll go through first some additional data and background history about where we are today in type 1 with respect to prevention and where I think we need to go. So hopefully this will be a little bit of a thought-provoking presentation to help us define really what precision prevention means for type 1 diabetes. So this is data taken from the T1D Exchange registry, and what it shows is that, you know, despite all of the wonderful advances that we've had in the type 1 space, there still really is a high unmet need. And so what you see here is A1C numbers over time, and actually the orange line on the bottom is data from a few years ago, and the blue line on the top is the more recent data. So again, despite us getting better with understanding disease pathogenesis and progression, despite the new tools and technology we have, closed loop systems, CGMs, we still are not achieving targets. And another big concern too is that DKA is extreme. Children are diagnosed in DKA. There's some really good data suggesting that DKA diagnosis leads to poor outcomes, both in the acute setting as well as long-term. Again, during this morning's workshop, Dr. Mike Holler talked about how teplizumab is currently undergoing review by the FDA, but where we are right now, there are currently no approved disease-modifying therapies. So we still have quite a bit of work to do. And so the question is, how do we get there? You know, the incidence, at least in most Western countries in the US, is about 1 in 300 people have type 1 diabetes. So we're looking for a little bit of a needle in a haystack. And how do we find that needle? And so really there's been some wonderful work, and I'll go through some of that data about the starting point as the genetic risk. Everyone who has type 1 has genes associated with type 1 diabetes. And we can get that, and the other way that TrialNet is looking to identify people that are at risk for diabetes is looking at family members. And I'm sorry this didn't go through, that family members are at a 15 times greater risk of developing type 1. So the relative risk is about 1 in 20. And so what this shows you is that genetics play an important role in type 1 diabetes, but is not obviously the entire role. And so what I'm going to show you next is some work done by Richard Oram and others to look really about how can we better refine the risk for type 1 with a genetic risk score. And so he and others have developed these genetic risk scores, and this is the most recent data taken from a 2019 paper out of Diabetes Care. And really what it shows, and this is what he's defining as the GRS2, and I'll just really show the comparisons on the left are with the GRS1, the first iteration, and the GRS2. And you can look at both controls and individuals diagnosed with type 2. And really what this shows is that the GRS2 can help better refine the risk for type 1 diabetes, both in the adult population, as well as to provide us some clues about how we can better refine risk starting in the newborn state. Now, what you'll see is this is a continuous variable score, and you can sort of put the cutoff anywhere to change your sensitivity and your specificity of the GRS. And so this has important implications as we think about population-based screening and mitigating both the sensitivity and specificity and false negatives and cost as we think about population-based screening. One of the things that we've heard a little bit about today, but I don't think enough, is that demographics really need to be part of the conversation when we're talking about precision prevention. And so this is the most recent data from a year ago from the CDC and from the search study looking at type 1 diabetes incidence among youth in the United States. And what you can see is that over time, you can see slight increases in most populations, but I think what's most stark is both the most recent rise in the African American populations here in the US. We know that this is a traditionally underserved population in the United States in the healthcare setting, and I think those stark inequities have been really highlighted over the past year during the pandemic. And so, when we think about making sure that we're treating all patients in an equitable manner, we really need to better understand how to define risk in all populations. And so one of the concerns, we just talked about the GRS, the genetic risk scores, is that most of these have been developed on largely Caucasian populations of people of Northern European descent. And so there's been quite a bit of work that's been done looking at how these perform in African American populations. And so the panel on the left is from Steve Rich and the T1DGC and search study looking at sort of the European-based GRS and how it performs in African Americans, and then developing a specific African American GRS. And you can see that it does improve the prediction using a more specific GRS. And then similarly on the right is work done by Todd Brusco and others at the University of Florida, looking at, again, an African-American derived GRS and showing improvement over normal European derived GRSs. One of the challenges that we face here, especially in the United States, is understanding, how and when to implement different GRSs, especially given the heterogeneous and the admixed nature of our populations. And so I think this is specifically highlighting an area that we need to really focus on and pay attention to, especially as we're developing broad population-based screening approaches. Earlier this morning, Dr. Redondo already talked about the staging of type 1 diabetes. And so I just put this up here again for those of you that were unable to attend her talk. And really, some seminal work done by others has really shown that type 1 develops in a predictable manner. And, we have stage 1, which is individuals with autoimmunity with multiple autoantibodies, stage 2, where dysglycemia begins, and then ultimately stage 3, which we term as sort of new onset or symptomatic type 1. And the data really shows that once you have multiple autoantibodies, your lifetime risk of developing type 1 diabetes approaches 100%. But one of the challenges here is this variable rate of progression to type 1. Some develop very rapidly, while others can take up to 15 or 20 years to develop type 1 diabetes. So when we think about interventions and approaching this from a risk-benefit standpoint, we need to make sure that we're intervening in patients at the right time with interventions that make sense for that individual patient. And so one of the things that, again, Richard Oram and his colleagues and work out of the TEDdy study here has shown is that combining risk scores can really predict future type 1. And so the two panels here, one was the landmark age of 2, looking at prediction over different prediction intervals, and panel B is a landmark age of 4, looking at different prediction intervals. And what you can see here is that antibodies alone are very good at predicting ultimate time to diabetes, again, over a 3-year prediction or an 8-year, the green versus the purple. But when you add the GRS score to that antibodies, as well as family history, you can see that that vastly improves the prediction of future T1D. Interestingly, the addition of country, sinusitis, and weight don't seem to add much value to the combined risk score. So scores like this can help us predict and improve prediction. And this could be really important as we think about population-based screening approaches, as well as prevention trials and ultimately therapeutics. So if, again, we can predict those who will develop type 1 more rapidly, it could help us in our clinical trial design, as well as I'll talk about the heterogeneity of type 1 diabetes. Another study that is doing work in this area is the TIDI, the Type 1 Data Intelligence study, which is a partnership between JDRF and IBM Research. And this is data presented last year at the NPOD meeting, really taking a machine learning approach and looking at different patterns of development over time. And what you can see here, and I think this is important as we think about the heterogeneity and sort of subtypes. Some people like to sort of bucket type 1 into endotypes, but really what it is more of a probabilistic state. And that's actually what the grouping here on the left shows. When you see these numbers, this 0.92, 0.94, it's the probability that somebody has that. And so you can see here, and for example, this group that's multi-autoantibodies, the probability that they have GAD when they enter the state is 92%, and the probability that they have insulin autoantibodies is 59%. And so what that tells you is that not everybody that fits this sort of pattern has those characteristics, but the vast majority of them do. And what you can see here is in this, again, machine learning type of approach, is that there do seem to be different types of trajectories, different pathways to type 1 that are highlighted by different patterns of autoantibody positivity. And so again, this could be a tool that helps us to better refine those that are at risk of developing type 1 and understanding their pathway to disease. So tools like the combined risk score and these tools to understand the underlying heterogeneity in the disease will be really important as we think about developing therapies and refining the risk and rate of progression to type 1. And so in the last couple of minutes, I just want to spend some time really talking about the sort of the how, when, and where should we intervene. And so where we like to think about this is this idea of prevention is really before the onset of type 1 diabetes. But really what the staging paper has shown is that type 1 diabetes begins at the point that autoantibody positivity has begun. So it's really about disease interception. And there may be different ways to intervene, whether it's environmental therapeutics, immune or inflammation based targets, or ultimately also beta cell health and function targets. Dr. Haller also talked this morning about the idea of combination therapies. And I think what this also shows is that at different stages of the pathway and the progression to type 1, there may be a need for different types of intervention. And so the key is understanding which of these interventions is right at the right amount or at the right time. And so just quickly, this was also mentioned earlier this morning as well, that teplizumab has shown that a single course of teplizumab can delay type 1 diabetes by over 32 months. But one of the things too is that you can see again the large variability here, and predictive biomarkers at baseline remain elusive. So we don't know at time zero sort of who is going to respond to therapy and who is not. They did show some nice work showing that responders showed some differences at 3 months, again, but not at baseline. This could be potentially, as we have different tools in our armamentarium, we can maybe use these early biomarkers to move on to the next therapy if we can predict that these individuals are not responding to therapy. One of the major challenges in the field is that to date, no biomarkers have really been consistent across trials showing responders versus non-responders. And so again, this is a really important point for us to understand as we move forward. A couple of folks this morning also have talked about age being an important factor too. And so this is incidence in men and women over the lifespan. You can see that type 1 has a peak incidence in adolescence. Interestingly, it seems to sort of flatten out during middle age and increase as individuals get older. One of the challenges, and this was also touched on this morning, is that most of our understanding of type 1 diabetes pathogenesis has come from studying children's, and this may not apply to adult onset type 1. So this is really important. There have been some reports that misdiagnosis can occur in 30 to 55% of adult onset type 1s. Most often they've been diagnosed as type 2s. As a side note, when a family member was diagnosed wrongly with type 2 as an adult, and based on my advice, went back and told her doctor that we think she had type 1. Her physician actually told her that adults don't get type 1 diabetes. So there's still a lot of misunderstanding in the healthcare field as well about type 1 diabetes. And so one of the things that's really another major need for work here is how this misclassification impacts treatment, both in terms of acute and long-term complications in adults. So just finishing up my talk here, I've touched on much of this already, is that we need better predictive and prognostic biomarkers to appropriately intercept type 1. So if you think about the disease interception paradigm, we can identify those at risk, monitor them, intercept, and if they are not responding to therapy, or if they start changing the course of their disease progression through biomarkers that monitor progression, then we will intercept again, intervene again with the different types of therapy. And so maybe in the interest of time, I'll just end on 2 quick slides. And so where do we go from here with precision medicine? I've already talked about the idea of composite risk scores to better define risk and rate of progression, to appropriately stage individuals for inception therapies. We need new biomarkers to be pursued, and some of the things I talked about in the last few slides. But one of the things that we've not talked a lot about over the last couple of days is the pathway to commercialization, and how do we engage diagnostic companies to pursue biomarkers in this space. And finally, an investment in disease-modifying therapies with collaboration across sectors, so from industry, academia, and others, to basically underscore and better understand natural history, and to drive ultimately patient impact. And then, once we've sort of figured out the science, I think one of the things, again, that we haven't spent a lot of time on is really looking at what impact the local ecosystem might have on adoption. We've talked a lot about type 1 diabetes in Western countries, but even there's a lot of differences in terms of how different countries and different states may take different approaches due to some following differences. We think about the healthcare system differences, single versus multi-payer, socioeconomic factors I touched on a little bit that may exacerbate disparity. And certainly when we think about type 1 diabetes, primary care will be a really important touch point for initial identification of risk, and yet different countries have different primary care models. So what works for one will not work for all. Again, touched a little bit on demographics and epidemiological differences that exist between regions and even within regions. And major countries will often rely on their own public health research for adoption. So this is, again, a barrier that I think we need to better understand. We heard earlier in this session from a couple of speakers from South Asia, and so what's defined success in Western countries may not translate to countries with lower incidence or with countries with lower income. And finally, economic, political, and cultural differences. Again, most policymakers are focused on their own geographic location, and so how do we expand findings from one or success in one region to another. And really important as we think about newborn screening, which I didn't talk about a lot, but in the US, states often have different screening uptake rates. And this may have really important impact for population-based interception. And so I would just like to end with a thank you. And despite all these challenges, doesn't mean that we shouldn't forge a hope forward. Leave you with a quote from one of my heroes, Ruth Bader Ginsburg: real change, enduring change happens one step at a time. And thank you for your attention.
And thank you for that wonderful talk. That was just great. And I want to actually thank all our speakers for their outstanding presentations.